Hello, good afternoon, everyone. Thank you so much for joining. Can I just check that you can all see my screen?
Yeah.
Wonderful, thank you. Again, thank you so much for joining. My name's Norma Findlay and I am Head of Clinical Operations. And today we're going to be looking at moving and handling risk assessment, taking that proportionate or best practice care approach. And actually, when I was preparing for today's webinar, I had to think to myself, so over the last 26 years, I've estimated that I've read and evaluated over 6,000 risk assessments, really as part of my OT practice, but also large-scale investigations and liability cases. So there have been many risk assessments that I've had sight of, and I'm hopefully been able to get a lot of opinions and experience that I can pass on to you today in line with best practice guidance. So when we'll think about risk assessment, well, it's the foundation of our safe people handling. Specifically for people handling, its purpose is not just, well, we don't use it as a means of identifying reasons why a task can't be undertaken or to eliminate risk completely. Instead, we see it as a process for determining how an activity can be completed really safely and proportionately and in a way that maximizes a person's independence, dignity, and participation. Of course, we work within the legal requirements and the framework, which, if we think about the Management of Health and Safety at Work Regulations 1999, the regulations require employers, so as with all the regulations, have duties upon the employee and the employer. So those regulations require the employer to carry out a suitable and sufficient assessment of the risks to the employees and others who may be affected by work activities. Of course, when in people handling, this means considering not only the safety to staff, the carers, but also the safety and well-being to the individual being supported. And those regs provide that overarching framework. We then have, of course, the Manual Handling Operations Regulations 1992. And we'll look a little bit in more detail around that avoid, assess, reduce, that hierarchy which applies under the Manual Handling Operations Regulations 1992. But of course, we're mindful that the Manual Handling Operations Regulations were not written specifically for health and social care. They are generic and they apply to inanimate as well as animate load handling. But as we appreciate that working with people is very different to working with those inanimate loads. And when we consider, unlike a box or a piece of equipment, a person can often participate, they can move in their own environment, they can communicate, they can potentially learn new skills and make improvement over time. So for this reason, we apply the Manual Handling Operations Regulations. However, we also look at that wider picture of best practice guidance in working with people. We have additional guidance from the Health and Safety Executive who defined the risk assessment that we're completing as a careful examination of what in your work could cause harm to people so that you can weigh up whether you've taken enough precautions or should do more to prevent harm. And within working with people, this definition is expanded by our professional practice to recognise that risk assessment must also promote positive outcomes for the individual. So the risk is not eliminated at the expense of independence. Instead, it's managed through our professional or our clinical judgment, making a suitable, and I'll carry on referring to this term, I'll expand in a little bit around what would constitute a suitable and sufficient risk assessment by a competent member of staff. So what defines a competent member, and ensuring that a person-centred decision-making approach is taken. So that proportionate handling of processes are sometimes called optimized handling or handling with dignity or getting the right size care, for example. It's our current best practice. And within people handling, this includes obviously legislative compliance and it incorporates that evidence-based practice. So drawing on health and social care guidance, It includes the Care Act 2014, the Equality Act 2010, and also considering our professional guidance from organisations such as NBE, so the National Back Exchange, RCOT, and the High Impact Change Model for optimised handling. So if we think of those collectively, then we can recognise that supporting movement is not simply about reducing the risk, but it's also about promoting rehabilitation, reablement or enablement, recovery in certain circumstances, and ensuring that we have dignity, choice, and independence. So rather than assuming that the safest option is always one that involves more staff or more restrictive equipment, proportionate handling asks a different type of question. So we're thinking about what's the safest, most proportionate and least restrictive method of supporting the individual, whilst enabling them to do as much for themselves as they possibly can. So this approach often challenges sometimes some of our historic approaches, where tasks are routinely, for example, completed by two carers or two members of staff, two handlers, sometimes in the situation where there's a mechanical equipment, often being introduced without full consideration of the person's remaining function. And whilst these approaches continue to contribute sometimes to physical deconditioning, increased dependency, and ultimately a negative impact on health and well-being, they might be reducing the risk, but not the risk of deconditioning or reduced independence for the person that we're supporting. So when we take a proportionate people handling approach to risk assessment, we're considering all of the evaluation of the person, so their function, their mobility. We'll come to look at this when we actually look at carrying out the Tileo, but we're considering pain, muscle tone, any of those behaviours that we may consider challenging, any impairment in cognition, but also their ability to participate, their goals, their wishes, and their level of quality of life and independence. So the outcome we're looking at with regards to proportionate handling is not simply about the safest in terms of physical risk reduction, but it's the safest reasonable option that balances the health and safety with the person's right, rehabilitation, and individual goals. And so when we come on to that Tileo framework, or some of you might be using a Liteo framework, this thankfully is all familiar to us. So we're not having to look at anything that's particularly new, but we're ensuring that it's in line with best practice guidance and that proportionate handling approach. So this is a great framework for our risk assessments within moving and handling as both a recorded and a dynamic risk assessment. And the Health and Safety Executive Guidance on Manual Handling applies the Tileo and states that it should not just be seen as a simple checklist for identifying manual handling risks, but it should be seen as a framework which supports that safe decision and balanced decision making. So when we think about the task, in proportionate handling, the assessment begins by considering what does the task involve, and rather than just saying how do we move this person, the assessor is asking why the movement is undertaking, whether it's necessary in its current forms, what are the goals to be achieved, could the activity be simplified, for example, could it be broken down into smaller stages? Is there a different method that would allow the individual to participate more actively? And within proportionate handling, the task is not viewed as a fixed procedure because we understand this is dynamic. However, we have to understand as the assessor that we need to decide what the task involves. So for example, rather than completing a full hoist transfer because that has been historically been the routine practice, the assessor considers whether a standing transfer in some cases may be more appropriate, or repositioning techniques could be safely promoting greater participation. So what is the actual task? The individual we need to consider, especially within proportionate care. Have the carers been trained? Do they have the adequate ability to assist, the knowledge and skills? And what are their historic practices saying? So this is really when it comes into their training and their approach as well, and also their perceived exertion. So we'll come on to look at the differences in different carers' perception of exertion in certain tasks as well, which makes a difference when we're looking at proportionate handling. Now, within the manual handling operations, we understand that the load traditionally refers to the object being moved. And in people handling, the load would be defined as our person, as well as the equipment, etc. But therefore, it does require a fundamental different approach. As I've already mentioned, people are dynamic, we're different, we're not static. They may be able to maintain weight bearing ability, for example, may be able to assist with movement, changing position, etc., and be able to communicate discomfort or comfort at the end of the manoeuvre and during the manoeuvre. And so we need to think about the assessor's ability to not only think about the size and weight of the person, but also assessment of their ability to move those patterns of movement, balance, that functional ability and muscle strength and pain and any behaviour that we need to consider as well. So that's the distinction highlighting why this proportionate people handling approach is different to our load handling risk assessments. But we're still taking the TILEO or LITEO approach. And the environment can often determine whether a movement can be completed safely. So we'll think about those space restraints, and that can sometimes help us to justify some of our reasoning. So rather than conclude that a task is unsafe because of environmental constraints, proportionate handling would encourage us as assessors to consider how the environment can be adapted. That might be small changes and alterations in furniture, etc., but we're looking at maximising participation and reducing the risk. Other factors is a final stage that offers, it may influence a handling activity. So this can be the organisation's procedures, staff competence again, and their availability of equipment that can affect your decision and the outcome of the risk assessment. And within proportionate handling, as assessors, we're encouraged to balance that potential risks that have been identified through TILEO to encourage that balanced potential risk against the benefits of maintaining independence and encouraging participation. So this is supported if you want to have a little look at some of the research. So we have one by Whitehead and colleagues back in 2022 there was a national survey of English local authorities, and they found that person-centred occupational therapy enabled proportionate handling to take place by tailoring care packages to the individual's needs, but whilst almost at the same time maintaining safety and independence as well. So we're honing into our framework that we know very well, but also that evidence-based practice as well. So what might it look like? Well, I'm not saying this is your best example of a moving and handling risk assessment. As I say, I have come across many, and I will talk to good and not so, I would consider well-placed risk assessments. But the risk assessment template is your structure for identifying those hazards, evaluating the risks and determining the safest and most proportionate method of supporting an individual during the transfer. So it's not intended to identify reasons why a task can't be completed, but to establish how it can be done in a safe way, promoting dignity, independence and participation. I have always, in all the many years that I've been delivering training and supporting moving and handling, I've always viewed the Health and Safety at Work Act as a means for participation rather than seeing it as a way to stop any activity from taking place. And your assessment should bring together those key principles of TILEO by considering the individual, the task, the environment, and the staff capability, and also any additional factors as well. The assessment should be completed before the moving and handling activity, and then it just should be a date for reviewing, and obviously reviewing it whenever the individual's condition changes, for example, when there's any changes to the environment or equipment. So by following a structured assessment, organisations can demonstrate that they have compliance with the management of health and safety at work regulations and the manual handling operations regulations, and our current best practice guidance for proportionate handling. ensuring that the individual and those providing care are protected whilst achieving best practice outcome. I would just recently, actually, this week, I put a little note to myself here to say, be careful when you're using additional tools or where your risk assessment refers to additional tools such as REBA or FimFam or others where they're not actually being routinely used. So this is something I've came across where scoring was referred to, but no one in the team who's carrying out the risk assessment has been trained in. And actually the law does not require these additional tools. So you're best to stick with what is required of you. And that is the TILEO framework. And we take that information and then we're able to formulate a handling plan. And that is really a translation of the findings from your moving and handling risk assessment into a clear, safe system of work, of which we would tend to describe as a handling plan or a care plan rather than a safe system of work. But that's what's being required of us to provide care. And we know that the expectation of the manual handling operations regulations for our care staff is to follow that clear, safe system of work. So we have to be clear in what we're asking the care team to do. It provides practical guidance on how specifically activities should be carried out. So that should be a description of a safe manoeuvre, identifying the number of staff required, the equipment to be used safely, and for the agreed method for each transfer. And obviously, if there's anything specific to that individual, that should be included in there as well. I'll work with children as well as adults, so it wouldn't be unfamiliar for me to come across reference to singing certain songs in a handling plan. Tends to be more with children, but whereas in adults, there has been reference to, I think of One Direction being played through a microphone through a speaker to provide such calming for some people. I have to say, I would be encouraging myself to sing during a manoeuvre. I think that would cause more anxiety. But you get the idea of the method and the types of suggestions might be specific to that individual. And the handling plan shouldn't be viewed as a fixed document either. We need to review this and it should reflect that person's individual functional ability at the time. So if the person is on a rehabilitation journey, or if we have somebody who is has a neuroprogressive condition, for example, or any palliative condition, then we need to make sure that we change and update this handling plan as well. I would consider that a well-proportioned or well-developed handling plan should promote a least restrictive and more proportionate approach, encouraging the person that we are supporting to do as much for themselves as they safely can. It should support a rehabilitation approach and maintaining independence where we can, and that it should see that it's person-centred and applying that person-centred guidance or best practice guidance. And that being said, a common misconception is that a good risk assessment has to be lengthy. And whilst I am indeed a fan of Leo Tolstoy, both his literacy work and his poetry, I would say that it does not have to be a lengthy document. Over the years, I have encountered digital moving and handling risk assessments. So I can think of one case where the risk assessment exceeded 128 pages. Yet, despite its length, it failed to provide clarity or any guidance or really tell me as a reader what was expected of the person. So if you think of the legislation, could I follow the safe system of work? No, it was not clear what the equipment was to be used, how to approach the task, the method, or indeed the number of people to assist. So whilst, as I say, great admiration for War and Peace, it's certainly not what we're looking for in a people handling risk assessment. A well-written assessment should be concise, person-centred, and proportionate, providing a clear, safe system of work or a clear care plan or handling plan that can be understood and followed by those delivering care. And in the next section, we're going to look at what is meant by that definition of suitable and sufficient risk assessment, because that's really what we're being asked for here. And it should be completed by a competent person and how those risks can be reduced, again, so far as reasonably practicable. We'll look at that in a little bit more detail whilst promoting independence, dignity, and safe practice. I think of one case actually where I remember it was a large-scale investigation. One of my colleagues, who's an exceptional OT, he had completed a full course in risk assessment. And when it came to me looking at evaluating his risk assessment of these cases, there was one manoeuvre. It started off as a very in-depth, but he described that he observed the transfer with the carer standing to the left side of the patient with their right hand on their left shoulder, with their left foot next to their right foot, holding on to the person's hand. And it was so complicated trying to reenact that. We had to explain that whilst you do want to be detailed, you choose the details that you provide. So be mindful of that and being concise, and that you have to be able to follow the risk assessment. So what is the assessor's role? And when we're considering that competency now, in moving and handling, we've been talking for competency for quite a few years now. We tend to refer to competency now, which is an excellent way of doing our refresher training, for example. But let's just take about what does the legislation ask of us, as a competent risk assessment or a competent risk assessor. So a risk assessment actually is only as good as the person who's conducting it. So that competent assessor does need to have legislative knowledge and ergonomic understanding. They do need to have that clinical reasoning to be able to pass comment on recommendations, and also have an awareness of the equipment available, be able to weigh up that risk-benefit decisions, and understanding of proportionate handling or optimized handling principles. So risk assessment is often viewed just as that process of identifying hazard and recording the control measures. However, within proportionate handling, an effective risk assessment is far more than that. It is about that professional decision making. And we know that from cases such as back in 2003 in East Sussex, where Lord Justice Mumby really didn't favour that blanket approach. He very much highlighted the need for a risk assessment. So ultimately, our risk assessment is looking at that balanced decision making, and we know that the law favours that rather than taking a blanket approach. So the importance of that competence is recognised throughout health and safety legislation. We see it appearing in the Management of Health and Safety at Work Regulations 99. So that places a duty on employers to appoint a competent person to assist them to complete their health and safety responsibilities. And that's under Regulation 7. The regulation states that every employer shall appoint one or more competent persons to assist him to undertake the measure he needs to comply with the requirements and prohibitions imposed on him or under the relevant statutory provisions. And then the guidance that accompanies the code and practice guidance further clarifies this by stating that a person shall be regarded as competent where he has, I should say he or she, but I'm quoting from the guidance here, where he has sufficient training and experience or knowledge and other qualities to enable him to properly assess and undertaking the measures. So this definition is particularly significant within people handling because it makes clear that competence is not defined by a job title, professional registration, or attendance at a training course alone. That competency is a combination of knowledge, training, experience, and the ability to apply clinical judgment in practice. Now, we'll look at some case examples just towards the end of our session today. But just to be clear that, having competency and making sure that you're confident, it comes with experience also. Definitely making sure that you have adequate training, but that you also have the ability to assess functional capability as well of the person that you're assessing. So let's apply some of our principles of safer handling and what the legislation states under the manual handling operations regulations. So this is familiar to us, very familiar, where we have avoid, assess, reduce, and review. So this is our 4-step hierarchy, and we know that our first step is to avoid hazardous handling where reasonably practicable. We'll come on to look at what that means shortly. And people handling, that avoiding movement or activity, it's not just saying about avoiding harm, but we can see that as a potential to encourage movement. We can see that as an opportunity for the person to assist. But what we don't want to do is avoid the task. Other words, we can be taking away the person's ability to participate in life. And of course, where it can't be avoided, because we don't want to say, I will give an example here where in my experience, sometimes a task can be avoided and we are providing full care on bed, for example. However, avoiding the task in the longer term then exposes the individual to other secondary risks, and that's the individual in the bed rather than the handler, the person handling. So where we can't say that we're avoiding, and obviously even where care is providing in bed, we still need to provide a lot of care, then we need to assess that, and we need to be working towards those goals and reducing the risk. So a proportionate assessment considers much more than just the task itself. It balances out the person's functional ability, their mobility and cognition, and their rehabilitation potential as well. So we're making sure that we're recording this in the avoidance, the assessment, and then we're going to reduce the risk so far as reasonably practicable. I'll come on to look at what that is. So when we are reducing the risk, this is a fundamental part of health and safety legislation. It recognises that risk is not going to be eliminated. So that's one of the things I always say to the people that I support with risk assessment is, don't consider that when you are signing off the risk assessment, when it's your name on that risk assessment, it's not an expectation that you have eliminated risk. So I think sometimes there is that fear there that, if I put my name to this, then I am liable. But ultimately, you're only being asked to carry out a suitable and sufficient assessment. You should be the competent person, and you're being asked to reduce the risk so far as reasonably practicable, following best practice guidance. And our best practice guidance within optimised handling means selecting the appropriate equipment, improving the environment where we can, developing staff competency, and adopting and adapting handling techniques to minimise the physical demands, but also enabling the individual to participate as much as they can. And the final step is that review. So people are not static, neither are the handling needs. So we need to ensure that we have a review process in place where we can follow the principles of the avoid, assess, reduce, and review. Now, what do we mean by a suitable and sufficient risk assessment that keeps coming up time and time again? And this is something that I will look at in an assessment, especially where there's been any incident. We do not live in a world where we can completely avoid any injury. So where there are any significant injuries and I'm being asked to pass comment, then when looking at a suitable and sufficient assessment, this is a legal requirement, and under Regulation 3 of the Management of Health and Safety at Work Regulations 1999, it requires employers to assess the risk of employees and others who may be affected by their work, and this means carrying out that assessment. But when it talks about a suitable and sufficient risk assessment, it is far more than just a form. This is your professional judgment and considering the individual's ability, their rehabilitation potential, and saying that I'm a competent person and I'm able to weigh that up. So the approach and being a competent assessor, you should be able to explain why a particular handling method has been selected, and what risks have been identified, and what control measures you've considered, and what are required, and why the proposed level of support is proportionate. So the assessment should clearly identify what the person can do, as well as the assistance that is required, specify what equipment is needed. We've gone through the basics of that, and it should also be reviewed as well. So it aligns this suitable and sufficient risk assessment aligns with an optimal handling or proportionate handling approach where decisions are based on assessed need rather than potentially a historical practice or routine staffing levels. So that's something that sometimes we see is just a risk assessment based on what's always been done. A risk assessment is suitable when it does accurately reflect the individual's current circumstances, sufficient when it contains enough information to justify the handling plan, and proportionate when it manages the risk without unnecessarily restricting independence and participation. So the assessment will then come in to answer the question, how can the person be supported to carry out the activity in the safest possible way, so far as reasonably practicable, which is what we'll come on to look at next. So making sure that it is indeed a suitable and sufficient risk assessment, not War and Peace. And reducing the risk so far as reasonably practicable. So in training, if you come to any of our training, we really hone in on this. So it's one of the fundamental principles of UK health and safety law, that the risks should be reduced so far as reasonably practicable, not eliminating the risk completely. This principle is established in Section 2.1 of the Health and Safety at Work Act in 1974, where it states that it shall be a duty of every employer to ensure, so far as reasonably practicable, the health, safety and welfare at work of all employees. Sometimes this term practicable sounds a little bit made up, but trust me, it's not. So far as reasonably practicable doesn't mean that every risk is going to be eliminated, as I've said, regardless of the consequence. Instead, it requires a balanced decision making. So balancing the level of risk against the sacrifice required to reduce the risk. And its principle was established in a landmark case back in 1949 of Edwards versus National Coal Board, if you're interested in some of our court cases. So the court confirmed that the measures required should be weighed against the degree of risk. And if the sacrifice in terms of time, effort, inconvenience or costs is grossly disproportionate to the reduction in risk achieved, further action may not be reasonably practicable. So practical terms, the first thing is the likelihood that the harm occurs and the severity of the potential outcome. And then secondly, the time, effort, energy and costs that would be required to reduce the risk further. So where simple effective measures can significantly reduce a foreseeable risks, then they should be implemented. However, where a further control measure with little additional benefit may be required that's disproportionate, then the law would not require that to take place. And within proportionate handling, this principle is particularly important. So considering staffing levels or introducing a more restrictive equipment would not be seen as so far as reasonably practicable. Instead, what we need to do is we need to be seen to maintain the individual's dignity, independence where possible, and participation, along with that professional judgment, weighing that up of the cost of making sure that we have adequate trained carers, for example. And we'll have, I'll give you one example of a case study at the end of today's session where we can reduce the risk so far as reasonably practicable, where we may have difference in opinion of the risk. For example, I mentioned that you may have a carer who has a different perception of exertion in certain tasks than others. That task might be rolling someone in bed, it may be moving a mobile hoist, but I'll come on to look at an example of that within current practice. So this is our current best practice. We look to the National Back Exchange. Many of you will already be members. If you aren't already, it's well worth looking at being part of this supportive community to follow the current best practice. They promote an optimized approach to moving and handling, and this adopts a systems-wide approach. So what we're referring to here is that we shouldn't be seeing a variation in assessment between, for example, hospital, respite, and home. And if we can have consistent recommendation, then this will optimize moving and handling plans and ensure that we are supporting safe, seamless care throughout the person's journey. We do, of course, understand and appreciate that the environments within a hospital and within the home are very different, but that doesn't mean to say that the approach needs to be particularly different at all. So same framework, same best practice approach, and that enables consistency and what we're articulating is required in terms of reducing the risk so far as reasonably practicable. So let's look at a case example approach. So this example that I'll discuss and happy to chat through with you is an individual who was had a hospital admission of 3 months, and on planning for discharge, it was ascertained that the person was able to safely use a stand-aid for transfers between chair, wheelchair and commode. However, the assessment identified that there was greater risk was identified when the person was transferred to side sitting on bed. So due to reduced sitting balance and limited postural support when side sitting on bed, the individual was at increased risk of losing their balance, and the handler had difficulty maintaining that. So this created the potential risk for staff to instinctively support the person's weight. So rather than progressing immediately to a full body hoist transfer, which was suggested because the person was still able to weight bear, they used a combination of one wedge to rear of person and one to side. And this enabled the person to be safely supported for the duration of side sitting on bed before then being assisted for legs onto bed and positioning. So a relatively small adjustment, but yet significantly improved the safety, but also allowed the person to continue weight bearing. And this would be considered reasonably practicable and ensuring that the risk is reduced so far as reasonably practicable. So let's look at another case example. We have here the individual requires a full body hoist for all transfers between bed and chair. Transfers are carried out using a mobile hoist assistance of one with a linear transfer technique. And the home environment provides suitable flooring and sufficient space to maneuver the equipment safely. The risk assessment confirmed that one trained carer is able to complete the task safely with no identified risks to the individual, and the person positioned correctly throughout the transfer. There was no evidence of any lower limb contact with the hoist mast, and the hoist transfer route allowed safe and controlled movement. So although the transfer was considered as low risk, there were some carers who reported that manoeuvring the mobile hoist required greater physical effort than others, particularly when aligning the hoist or changing direction. Whilst no musculoskeletal injuries were recording, the variation perceived risks highlighted that there was opportunity to reduce the risk again, and therefore there was potentially a case for installation of a gantry system. The decision was made to install a short piece of straight ceiling track hoist, and this was considered proportionate, and it was reasonably practicable considering the risks. So it was also providing a smoother transfer for the person as well. So all round, that was the decision made in this case. So when we think of those cases, there are many others where we can reduce the risk so far as reasonably practicable and ensure that the person carrying out the assessment is competent, and that also those working with the person are trained in dynamic risk assessment as well. So when we think about our completion of our proportionate care risk assessment, the risk assessment is a professional decision-making process. When I say professional decision making, I've already made it clear that that doesn't mean to say that you have to be of a particular title. As long as you are capable and competent, or as the legislation puts it, you're a competent risk assessor and you're able to combine your understanding and knowledge of the legislation, the evidence, the clinical reasoning and person-centered practice to develop a safe system of work, which is now considered proportionate or optimized handling. That effective risk assessment recognises that every individual we work with is, of course, unique. So whilst I'm often asked, can this be done as a generic risk assessment? There are indeed tasks that can be done for generic. However, when we're talking about proportionate handling, each individual is indeed unique and we need to record that. But again, that doesn't have to be a whole lengthy document for that. So by considering their functional ability and also the rehabilitation potential, what we can do or acquire to and what's available in terms of equipment to reduce the risk, but not to impose anything that is unnecessarily restrictive. So the aim we're seeing is we're not responsible for eliminating all risks because we want to achieve that, but we are responsible for reducing it so far as reasonably practicable, recording it so that we have defensible practice, and also ensuring that we follow best practice guidance by ultimately conducting a risk assessment that does more than just managing risk, but it enables safe, effective, person-centered cares and also applies those principles that we spoke to of proportionate handling. So hopefully that is giving you an insight into how for many years, how we've always worked in our TILEO approach, our risk assessments, that we don't need to change them all. There may indeed be some positive changes that you might want to make just for clarity to ensure that it is a suitable and sufficient document and that we're not overly asking for too much information within your risk assessments. And I'm more than happy to answer any questions that you may have as well. So I think we may have Alison to take some of those, if that's okay.
Yeah, so we have a question from Matthew. Can the safe system of work be in the same document as the risk assessment? The sections seem quite small throughout.
Yeah, I mean, certainly what popped on the screen there is not what I would classify as a perfect example by any manner or means, but yes, definitely, Matthew, you can have that included so it can follow on and actually works really well to do that. What I would say is my experience is, depending on how the information is presented, whether it be electronically to the care team or if it's in a ward setting, as long as safe system is clearly available and made it's easily accessible for anyone who's expected to carry out that task. So definitely can come at the end, but as long as it's not lost in the whole document of the assessment and isn't accessible. So that's probably the most important point I would make, is that it's accessible to those who are following it.
Okay, great. And then we commonly find that there is a significant lack of information within handling plans, which leads to risk/potential risk and lack of consistency in care and support for the individual. Sorry, I think it was just Diana was making a comment there. I think that a question from Christina. So this webinar is being recorded. So if you missed it or want to share it with your colleagues, we'll be sending a post-event link here very shortly so that you can share it, and it'll also be available on our website. So all of our webinars are on our website under resources and webinars. You can find them all there. I'm trying to think if there's any more. I'm reading through them all now. It's quite a long one. Working with care agencies who expect the OT to provide the risk assessment for the agency's own records, Where were you referring to where it says the employer, in brackets the care agency, is required to nominate slash identify a member of staff who is responsible for risk assessing on behalf of the employer? That's from Andy.
Yeah, so the employer will often defer to another to carry out that risk assessment. But with regards to specific care agencies, it is the carer's employer's responsibility to carry out that risk assessment. So whilst as an OT you might be providing the equipment, for example, and you would have a duty to risk assess accordingly and indeed share that, that would be expected. Ultimately, it's still under the legislative duties of the care agency as the employer to carry out that risk assessment. So it's not a you do it for, it's that share your risk assessment, but we will also have to do our own risk assessment as well.
Okay. And then I have a question from Elizabeth. Is there anything in the legislative framework you would add when considering children?
Yeah, so it is all there, and although I guess it's non-specific, so we have the manual handling operations regulations kindly provide such guidance as weight guidance, for example. So when I'm working in children's services, I often do refer to those weight guidance, and I see them being misinterpreted often. So where we see 7 kilograms, for example, from floor, those are the conversations, especially those children who are unlikely to become weight bearing, that we have to have conversations around a risk assessment. Now, this is sometimes people misinterpret those guidance in weights and saying you cannot lift a child more than, for example, 7 kilograms off floor, which of course is not what the guidance tells us. It leans into needing a risk assessment. So I would definitely use that within children's services and risk assessments. But also I've seen that misinterpreted within adult services as well. Often when I'm talking across the generations from working with children right the way through to adults, whilst obviously children are different because they are developing neurodevelopmentally, they are growing, we still have this, we still need to consider some of the potential in the adults we're working with. So the frameworks still apply, but what I would say is that the risk balancing out, we're still reducing so far as reasonably practicable, but I would just hone in on those weight guidance more than anything else, I think.
Okay, I think a few people have answered this in the chat, but maybe just to confirm, can we use Tilio without purchasing it or asking for permission? That's a yeah.
Absolutely.
Yeah.
Yeah.
Just some comments. Helen, whose responsibility is it to complete safer moving handling plans in care homes if they have assessed with their own risk assessor and chosen the equipment? In SS, we get a lot of requests for us to complete the risk assessment just for the paperwork.
Yeah, no, it is their responsibility. But as I say, if we're making any changes to that, so if I were, so many of the large scale investigations I think about going in, so the scenario might be that you're going in and you consider the technique to be either unsafe or not reduced so far as reasonably practicable, and you're putting in a control measure, and that would be recorded in your risk assessment. But because you're asking their staff to take that on board, they would need to review their risk assessment and update that as well. I think sometimes it's just about, working together and saying, I'm more than happy to share my risk assessment, but you will have to update your documents because you understand that, you have duties under the legislation, as I do too. So just being open with that and not trying to scare anyone into completing anything, but we're not asking for a huge task here. It is just ensuring that we're documenting. Most of the incidents I'm involved in, I could see where measures could have been taken, opportunities were missed, especially within care homes where there have been opportunities to make small adjustments so that the care staff could have followed a safer system, and those haven't been taken. So that's really quite frustrating and unacceptable.
I think you've kind of answered it just there now, but I'm in a nursing home. Do all residents require moving and handling risk assessments?
Okay, so moving and handling risk assessment is required where you cannot avoid hazardous handling, and one might suggest that any human being where you are assisting them to be moved or transferred, there is an element of you need to then assess that. It's unlikely, however, if you have individuals who are fully independent and require absolutely no assistance with moving and handling, then that would be the exception to the rule. But I do know that there are some generic approaches to take. I would be very surprised if there weren't every individual within the care home had their own individual risk assessments. But bearing in mind, I did refer back to a case of 128-page risk assessment, and it was not suitable and sufficient. It didn't have, it's electronic, but it really didn't have the basics. Sometimes a shorter, more concise risk assessment is more accurate and would be meet your legislative requirements and would be definitely considered defensible practice as opposed to 120-page electronic. So in response to the question of does everyone require, I don't know that because I don't know every one of the resident in that care home, but if they need assistance to be moved and transferred, then yes.
Okay, and we have two questions which are quite similar. So how do we stand with families declining OT risk assessments and advice within the manual handling plan? And then regarding family not agreeing to care package but wishing to move and handle themselves, expecting OT to provide the equipment.
Yeah, really absolutely valid questions. Good, really good questions. And as you know, as to say, over 25 years as OT, I find myself in those situations. What I would say is that when I talk through the risk assessment process, I do find getting engagement absolutely does help. Now, when we're talking about family or unpaid carers, we know that they're not bound by the same legislation requirements as you and I are, or any paid member of staff. That being said, if we've provided the equipment, we have our responsibilities under not just the Health and Safety at Work Act, but Provision and Use of Work Equipment Regulations. So we need to ensure that we have documented and reduced the risk so far as reasonably practicable. And if we haven't, then that would involve escalating that. So whilst we aren't expected to carry out a risk assessment where it is unpaid or family carers, and they don't always need to follow that, unless the question would be, are we talking about an adult who there are safeguarding issues? That's the other thing. So there are exceptional cases that we need to escalate if we consider that the person is being put at risks by decisions being made by their welfare or guardian.
Right, and just following up on that family member question, how do we document a family member is competent to use a piece of equipment provided by the OT, for example, a hoist?
Yeah, that's a really good question. So do that, document it. So if the scenario is that the person is, and I can think of a case that I was involved in where I did have concerns, but I documented everything. So the person did have capacity, as did the carer. I ensured that I had provided all the guidance necessary. So I had reduced the risk so far as reasonably practicable. I couldn't say that the family carer was competent, but I had reduced the risk so far as reasonably practicable, and I had documented that. So that's all the law is asking of you.
Okay, I'll try, and there's a couple of questions in here. Hopefully they're quite similar, touching on the same area. So from Jamie, when reviewing the risk assessment, including SSOW, is it best practice to just update the original document or provide new paperwork showing any updates?
Yeah, that's another really good question. It depends on your paperwork. As long as it doesn't become such a lengthy document that it's hard to, I'm a great believer of keeping things clear. So if you need to archive a historic document that doesn't relate, then just replace it. So it shouldn't be such a cumbersome task that if you're taking an update and starting with a fresh sheet, probably best. However, if the person has such a past medical history, for example, that's really complicated, then I would probably choose just to update to the existing. So it really, there's nothing to say that one is better than the other. It's really just based on the individual that you're assessing.
Okay, and then would you recommend a particular format for risk assessment? You kind of covered that a little bit, but do you want to clarify anything?
Yeah, I mean, we can provide you, we do have a template. That being said, the training I did last week there, when I looked at the council's risk assessment, I definitely preferred theirs. I think it was clear. I think it was a quite a short document. So I'm a fan of that. So there are examples that you can take and use from both the All Wales passport scheme as well as the Scottish manual handling passport scheme. So there are plenty of templates out there to use. I would just be mindful of what you require, and there's no harm in deleting aspects that you don't require. Just make sure that you include what is being asked of you.
Okay, and then sort of touching on the same thing again, we document the risk assessment within the person's records. It's not a specific document. Should it be from Linda?
Um, Good question, Linda. And I think that's what happened in the 120 page document that I was sent electronically. So yes, it should be clear that it's a risk assessment, especially where you have the safe system of work. So if your risk assessment and your safe system of work is within the care notes, are the carers, the healthcare assistants, whoever is performing the tasks, do they have easy access to it? So my only concern with it being included within all of the notes is that do they have easy access to that? And is it clear? So there are certain basic things, as well as following a tilio, there are certain basic things that should be concluded within risk assessment, and that is obviously the person who's being assessed, the location, the reason for assessment, but the assessor's name, the date. Those are things that I've come across that, and whilst I understand sometimes people forget to put the date on a document, often when I'm reviewing a risk assessment, it's not clear who conducted that risk assessment. So if we're trying to look at whether the risk assessment was carried out by a competent person, how do I make that decision if I don't know who carried out the risk assessment? So just be mindful of those basic details, that it should have a heading of moving and handling risk assessment. It should be clear when it was carried out, where it was carried out, by whom, and their role within the organisation.
Okay, great. This is the final question. Quite a few people leaving now. So just going back to when the family member risk assessment for using a hoist, etc. So Andy's just followed up. If we don't say the family member is competent, are we not liable because we provided the equipment? So that was then first question was, how do we document a family member is competent to use a piece of equipment provided by the OT? And so you had said to just
Yeah.
document it.
Yeah, I suppose it depends on what you mean by, do you mean they're unsafe? That's, are they competent? Do you have concerns? Is it unsafe? Are they safe or unsafe? Or because when we refer to competency in using a piece of equipment, of course, you're talking about not just safe use, you're talking about application of principles of efficient movement. And I wouldn't expect to see that from a family member. So the main thing is, are you leaving a piece of equipment with someone that you consider that it will be safe or unsafe?
Okay. Thank you. So I think that's I think someone's asked a question that we're really out of time. If your question wasn't answered or you were maybe Andy, if you need a little bit more clarity, if you email admin@a1momentum.com, we'll try and come back to you as soon as possible with answers to the questions. But again, this webinar will be recorded. There was quite a lot of resources mentioned, so we will try and include as many of those as possible in the follow-up email. And the next free webinar, I've just pinned it in the chat there with Lauren Osborne and Ruth Parker, so on the 21st of July. But thank you everyone, and enjoy your summer when it comes. Thank you
so much. Thanks everyone. Really appreciate you joining.